Assalamu alaikum and good evening to you all. Welcome to another medical educational program by SB Bangladesh chapter. We call it Health Talk on Acute Medicine, organized by SB Bangladesh chapter and supported by Bangladesh Society of Medicine. Today is the third episode of our series. On this episode, we are going to talk about emergencies in COVID-19. To talk about this important topic, we have someone who is playing a massive role in controlling COVID 19 in our country, whose clever, up to date, and very effective decision has saved many lives from the deadly effect of COVID 19. He is still working to prevent this COVID 19 from our country. He is none other than the line director of DGHS himself, Professor Amin sir. He is also the Secretary of Research, Bangladesh Society of Medicine. To chair the session, we have a legendary professor here with us, who is considered one of the best physicians of our country, the current governor of SB Bangladesh chapter, Professor H.A.M. Nazmul Hasan sir. He is the former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, Major General Professor M.D. Azizul Islam sir. He is the Consultant Physician General of DGMS. We also have Professor M.D. Hafiz Sarder sir. He is the Professor of Medicine, Dhaka Medical College. As a moderator, we have the handsome, talented, and every student's favorite professor, Dr. M.S. Arefin Patwari sir. He is the Assistant Professor of Medicine, Dhaka Medical College, and he is also the Member Secretary of SB Bangladesh chapter. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. M.S. Arefin Patwari sir. Dr. M.S. Arefin Patwari sir.
Thank you, Dr. Prince. Dear audience, ladies and gentlemen, good evening. I would like to invite you all to our today's health talk on acute medicine. And this program is organized by SCP Bangladesh chapter and supported by Bangladesh Society of Medicine. As we know that we are passing through a huge pandemic, and this is the COVID-19 pandemic. And despite all the measures taken by our health professionals and Bangladesh government, every day we are scoring the highest both in infections and in deaths. In this respect, our today's topic is a time-demanding topic entitled The Emergencies in COVID-19. And today we are very much lucky to have a renowned professor of medicine, Professor Muhammad Amin, and who is currently working as the line director, non-communicable disease control DG Health Service, and a secretary for research Bangladesh Society of Medicine. And today we are very much delighted having Professor H.M. Nazmul Ahasan, the living legend of internal medicine of Bangladesh, and actually, our sir is working for the students and working for the teachers and for the development of internal medicine in Bangladesh. By this time, sir has retired for 2 times, one from the government medical college and then from a private medical college. But sir has already proved that a retirement is not strong enough to throw cold water in fulfilling the vision of once. And he is working with his own tremendous pace still. And it is always inspiring for us. And today we are grateful because we have 2 panel of experts with us, and both of them are very renowned in Bangladesh. And Professor Major General Muhammad Azizul Islam sir, who is currently working as the Consultant Physician General and Director General Medical Services Ministry of Defense. And with us, we have got Professor Mohammad Hafiz Sarder, who is currently working as the Head Department of Medicine. My dear mentors and my dear respected teachers, I would like to welcome you all to our today's session. And now, without any delay, with the permission of our today's chairperson, Professor H.M. Nazmul Ahasan, may I request Professor Mohammad Robed Amin sir to start his today's session. Professor Mohammad Robed Amin sir.
Thank you very much. I think I'm loud and clear to everyone. Thank you very much, Dr. Arefin.
Yes, sir.
Okay, thank you very much for introducing myself. And I also like to thank Dr. Prince for introducing very nicely at the very beginning. Honorable chairpersons, our governor of the ACP chapter Bangladesh, Professor H.M. Nazmul Ahasan sir, our teacher, and he's definitely the living legend of our country. And the very respectable panelist today, Azizul Islam sir, as well as the Hafizul Bhai in the Dhaka Medical College. It's a pleasure actually to have the panelists with us, and as well as the listener. I mean, the listener would be definitely the physician I would expecting, as well as the students from the Bangladesh, maybe an international arena as well. So welcome. Today's presentation is going to be having emergencies in COVID-19. Whenever I got the topic, I was really surprised. What does it really mean? I was thinking, what may be the emergencies in COVID-19 era? I mean, if I can say about the emergency in COVID and outside COVID, it will be huge. So I will not be considering about the non-COVID thing. I will just focusing on the part of emergencies in COVID rather than go for the system. But before that, what I like to mention about emergency care system framework, which is very important for any emergency actually, I say. Because all around the globe, if you consider about the acutely ill as well as injured patient, the care system should be like this that I have shown in the infographic. Now, it does necessarily mean that acute complications of the infection, it also exerts when we are considering about the acute stroke, acute cardiovascular disease, acute injury, and even the acute complications of the pregnancy. If we really want to make an emergency care system framework work out in any country, they should be like this, because it will be started like here at the very spot when somebody like the patient or maybe a bystander will give a call like 999, 911. And obviously it will go to the dispatcher, and then we will see definitely an ambulance should be come out. As the provider will be there, this provider may not be a doctor, but he will be within a period of scene pretty quickly, because the bystander response and the dispatcher response should be pretty quick if you want to really care for the acute care. And the provider response will create an ambulance to go on and make it happen for the patient, because during the transport, it will not only transport the patient to a hospital or the healthcare facility, but it will care. I mean, this is called the transport care, where the positioning of the patient, some sort of intervention, and careful monitoring with simple things will be very crucial for saving lives. And so that you can easily see from the field, we are putting a healthcare provider pretty quickly and then handover system, while the driver actually give a call to the facility provider, and the provider will receive the patient pretty quickly. And you can see whenever the patient is receiving the facility, the emergency unit care will be starting blip. That's because there will be a red, blue, white, blue, as well as the yellow, blue, or the green code will be coming up. And the early patient care will be started immediately in the emergency area. And this will be consistent with assessment, resuscitation, intervention, as well as monitoring. And if some of the team actually believes that the patient needs an inpatient, he will go to the ward, and so the care can be taken. What a wonderful picture, isn't it? But the problem is that not every country in the world is having this beautiful emergency care system framework. And I'm very afraid to say that Bangladesh is not in this picture. So let's come to the emergency care need in the COVID-19. I will be just focusing on the COVID-19. So I will say that when actually COVID-19 patient came is a part of the pandemic, it's not an emergency actually. Pandemic is not an emergency, but there will be some situation in the COVID-19 which can be very much serious emergency. And I big into a different system. Like somebody can have a difficulty breathing or shortness of breath, it will be definitely an emergency. Somebody can have a persistent pain or pressure maybe in the chest, maybe a cardiovascular or respiratory emergency. Some may have a central nervous system mediated some sort of confusion, and inability to arouse, it will be definitely an emergency. Some may say just presented with a bluish lip or face, may not have any symptom, but it indicates this sign itself is an emergency. And certainly, when physician actually is checking or people believes there are other several symptoms that can alarm someone to have the emergency. So I will divide these things about the emergency care in the COVID-19 in such a way. And if you follow the national guidelines, as so many of the guidelines, there are two areas where the emergency setup is very important. One is the severe case definition clinically and the critical case definition. Because the primal point of these two cases of COVID-19 is the hypoxia. And remember, important issue, hypoxia is a real emergency. Why I'm saying this, when we are actually students of the medical science, we all believes in one part, but it's called the oxydissociation curve. And if you can remember the oxydissociation curve, it actually says that when the partial pressure of oxygen is around 60, you will be happy because more or less around that area or above to that, it is a horizontal. But below the 60 of the partial pressure of oxygen in the arterial territory, will have a serious amount of steep of that curve. Means that even a 2 millimeter or less of the PaO2 will have a serious problem with the SpO2. Means that hypoxemia and the hypoxia will be a very simple and serious issue whenever the saturation is actually fall below 90%. Because whenever it becomes below 90%, there will be a sharp decline to even 50, even 30 within a sphere of hours of the hypoxia. So you can easily see the emergency of so serious. That is the reason why most of the guidelines around the globe is actually focusing either you are dealing the central cyanosis or SpO2 less than 90 should be a level as a case of severe case of COVID-19. So that is the two. Another important is to count the respiratory rate. Some may not have an actual less than 90%, maybe around 91, 92%, but can have a respiratory rate more than 30. And still the patient will have a very severe case. So that's the reason why any patient, if subjectively observed with fever, cough, and fast breathing, and objectively observed by physician or any healthcare worker, I would say any healthcare provider, with a severe respiratory distress, either by means of rate more than 30 or SpO2 less than 90, should be labeled as a case of severe COVID pneumonia, need an immediate attention. And doesn't spare the children as well. So we'll be very considerate about the children to look after the fast breathing. And it may vary. Less than 2 months will have more than 60, 2 to 11 months will have more than 50, 1 to 5 years more than 40. These all indicate the seriousness of the disease. So what will you do is immediately go to the any kind of healthcare facility for triage. I will not say a lot of things about the triage, but my impression is that you will not be sure when a patient will have a cyanosis by subjective ailment or less than 90. So the warning will be around 92%. I mean, below 90 is 92 or below when the patient will be attending the triage system. As because there he will be leveled by means of guideline into a moderate, severe, or critical illness. And if it is a severe critical, he needs to be treated immediately because the primary principle of the critical and severe illness is the resuscitation and not the recovery. So what will they do? I mean, the principle will be definitely oxygen therapy because that has been proven. Hypoxia is the main cause of death, has been proven indefinitely in all over the countries around the globe of the COVID-19. If you consider about hypoxic encephalopathy, if you consider about the hypoxia ARDS and whatever the weight is. So the basic therapy will be always oxygen. But one important territory what I like to share with everyone that in the COVID-19, it will be escalating oxygen therapy. So people will start to give the nasal cannula at first 1 to 5 liters, check the saturation. Any blip in the saturation in any pulse oximeter is a real number. So don't just be confused with the numbers. Check whether it is below 80 or more than 88 or more. If it is below 88, you are not going to be rescued from the nasal cannula. You cannot provide the nasal cannula more than 5 liters because it will create turbulence and not delivery of the oxygen. So you have to choose in simple face mark. Again, check the SpO2 after giving the 6 to 10 liter. And if it is still remain less than 88%, we have the NRB with us with the reservoir bag. The NRV can give you the amount 10 to 15 liters of the oxygen, and still you can check it. If it is less than 88%, we can go to the high flow nasal cannula. And again, the high flow nasal cannula can deliver from the 30 liter to 70 liter. And interestingly, you can increase the FiO2 even up to 100% if we consider about to give the high flow nasal cannula. Beside the high flow nasal cannula, rest will not be given 100% FiO2, but it can vary. I mean, if you consider about nasal cannula, it will be around 40%, 20 to 40. If we give the simple face mask, it can give to around 40% to 60%. NRV can give you around 80%. Although somebody says the NRV can give you about 100%, but my impression is that whenever you're putting some mask, if the mask has some hole, it is the ambient air which will dilute, so it will never be 100%. And again, when somebody is giving high flow system, and still you're not attaining the hypoxia correction, there is the option of the NIV, which I will came later as the device is known as CPAP and BiPAP. And rest of all, if it is still failed, we can go for mechanical ventilation. So there are systems. I will be very much important to say about this system for the correction of hypoxia, because this is available in our country. This is the nasal cannula that I'm considering. This is the simple face mask. It is very popular right nowadays, the NRV as well as the reservoir bag. Remember, we have a huge number of the Upazila Health Complexes and district hospital in our country, serving many of the patients with the COVID-19 right now. As because we have a community transmission, not only from this metropolitan area, but for the villages. So these are very crucial. And it has been scientifically proven that low flow oxygen delivery system early is more beneficial and life-saving rather than the high flow nasal system. There is an oxygen alliance working in the globe, which actually give a recommendation to use this appropriately in the setting where you may have a high flow system and try to make a more lifesaver. Now, this is the right side, which is not a venti bulb or venti mouse, not very much popular nowadays in our country, but very helpful. Now, these are the areas where I like to mention that the flow actually dictates how much FiO2 is going to be generated. But for the venti bulb, it is the device that will dictate what percentage of the FiO2 and what ml of flow of oxygen can you give. So that is the reason why it's called the venti flow and venti bulb. So about the nasal cannula and the distribution of the face mask as well as the NRV, which has become very popularized to our country, I would say that we can save many of the patients if we can start it as quickly as possible, the hypoxia. About the NRV, I think the best option, if some of our physicians in any area is confused how much percentage of the hypoxia it is, whether the patient has got COPD, whether the patient has got asthma, underlying heart failure, if you have any confusion, I would say go for the NRV. Because when you're giving the NRV, you are giving a huge amount of oxygen in a pretty quick time, which will be around 80% give of FiO2, and it will help. Some may say whether this kind of high FiO2 is going to be beneficial for the COPD patient or not. I will say it can generate 15 to 20 minutes or 30 minutes, will not get any problem because it is the days, not hours, which is more important of hypoxia for COPD. And look at the different colors. The color actually dictate how much percentage of the FiO2 can give. Like that, if you choose as a bluish one, you can get 28%. If you choose a red one, you can give 40%. So you can see around 60% also oxygen can be provided through these different devices, color-coded. And right now, the newer technique is saying that why can we single use one and choose us to operate in such a way so that it can turn up into 24 to 28, and then 32, and then 60. So that will be fantastic devices, according to me, which we can also use for the low flow delivery system for a hypoxic patient as an emergency in COVID-19. So that's the Venturi valve, what I mentioned. You can see blue give 24, white 28, orange 31, yellow 35, red 40%. These all are FiO2 generated from the system of the device, not from the flow. And look at this one, you can also provide 15-liter flow up to the green mark. What about the partial rebreather? Is very popular in a Western country as because it can also have generated around 60% to 70% of FiO2 with a 6 to 10 liters. But this is the device that I'm saying, non-rebreather mask with a reservoir bag becomes a very popular in our country. And I would say that wonderful device for our low income country as well as the middle income country. What about the critical care emergency? I would say the critical cases of the COVID-19 is defined by fields of respiratory failure, who requires mechanical ventilation, sepsis and septic shock, acute respiratory distress syndrome, and any organ failure that require ICU care. Remember one important, I haven't mentioned about the pregnancy issue because these all are considerate when we are saying about the saturation of below 90, except the pregnancy. Here you should be more careful because any severe or critical emergency of the pregnancy will come whenever the saturation is go below 94%. How about the respiratory failure and ARDS patient to be given support as a part of emergency? I say that when you are considering about the ARDS, there is a Berlin criteria. Try to fix it up. We are considering the SpO2. We know how to measure it through a very simple pulse oximetry. But how about PF ratio? I mean, we need to go for the EBG to get the PF ratio, and then we can select the ARDS, whether it is mild, below 300 to 200 will be mild, below 200 up to 100 will be moderate, and if it is below 100, we are dealing very severe ARDS, possibly need to be have mechanical ventilation as well. Why I'm saying this? Because if we can consider about mild ARDS, we can start from the nasal cannula, then escalating the oxygen therapy that I have already mentioned. But if you consider about the ARDS criteria by means of moderate, we can be started with NRB. Just started with NRB, not to start with nasal cannula. And if you consider about the severe, we can start with a high flow even nasal cannula, or even sometimes the non-invasive ventilation in the form of CPAP, BiPAP, because the patient is actually so much emergency that he need to be intubated pretty quickly. So that is the reason why I'm saying this. The early intubation, late inpatient has become a big controversy. Actually, it's not the early and late issue. It is the indication where we need to give the mechanical ventilation is the more important one. So any degree of hemodynamic instability, any confusion, any kind of the patient who is irritable and not responding to the high flow system is going to be mechanically ventilated and get its benefit rather than late and late. So this is the high flow delivery system. We all know about this one. We can start with 30 liter, you can provide up to 70, and we can provide 100% of it. And flow rate, remember, although you can increase, should not be always synchronized with the FiO2 raise. It has a wonderful advantage, well tolerated, and people can eat and sometimes also talk if they are not so much of the hypoxic through this high flow nasal delivery system. But there are some problem with that one. And as because it can also dry up, can the humidified, and temperature can also give to crust formation, epistaxis. But overall, another important theory, you are dealing that 10 liter increase will generate a PEEP. So I will say that at least 5 PEEP can be provided by the high flow nasal oxygen delivery system. But remember, if any of the ARDS actually are thinking to give high PEEP, this is not going to be good devices because HFNO cannot provide you more than 5 PEEP. So it's a good one, definitely for the where the actually high central nerve oxygen delivery system is there, but sometimes it can generate so much oxygen consumption that other patient can have a real problem. So this is another alternative, I would say, for the very critically ill patient is the non-invasive pressure ventilation, where there are two things. One is called the CPAP, another is called the BiPAP. Now about the CPAP that I'm saying, when somebody is ventilated, you are going to be generated PEEP. Now that PEEP can be provided without any invasive process of the endotracheal intubation. That CPAP is actually nothing but the PEEP. So what will you do that during the time of expiration, normally our respiratory pressure remains 0. But if you consider to give a constant pressure around 5, it will also causes open up of all the alveoli that is closed in the expiration. So open up of this closed alveoli will create the high oxygenation in all the alveoli of the lung so that oxygen can be go through the blood vessel pretty quickly because oxygen is always the diffusion mediated thing. So even though the patient having an ARDS, if we can give a constant pressure in the airway and can make all the alveoli open, that will be fantastically given the oxygen to our system, so the hypoxia can be really corrected. I will be saying that it's not that expensive. It's not going to be generate so much of the high flow of the oxygen, but can give a similar effect like that of HFNO. What about the BiPAP? BiPAP, I would say that another system where actually you are generating more pressure over PEEP. Means that you are generating another pressure over the CPAP. Okay, so you are generating constant pressure around 5, and now if you consider to give another 10 millimeter of pressure, then this is called BiPAP. So that will be beneficial to whom? If you want to consider to carbon dioxide wash out from the lung, that will be best generated by giving bilevel PAP. So I would say if somebody has got COPD with COVID-19, I would say is any condition who has a carbon dioxide retention in COVID-19, go for the BiPAP and not for the CPAP. That is the very basic principle. So these are the few machines. I'm not going to detail anything, but what we need is to give a very tight seal mask. You can see, and the mask is actually will be provided in such a tight shield so that there will be no aerosol generation. And remember, through the system of the oxygen delivery, there's a filter which can also filter the virus. So that's the reason why what has been said is the aerosol generation procedure has not been proven so much high. If somebody has a very tight seal of the chamber of the mask and a virus filter within the system of delivery, that will be fantastic. I think the CPAP and BiPAP will be a revolutionary thing, especially if we consider to give treatment in the HDU or maybe pre-ICU. And there are also devices we have been seeing in the Italy and many other European countries, which is not a helmet device, where people can get some benefit, because some of the people will not get benefit after giving the high tight pressure masks. They get more discomfort. So for them, this will be a less generating of the oxygen. I mean, less generation of the aerosol generation, but giving very poor oxygen. And still, you need to give a lot of virus filter. Now, about this thing about the NIV, after NIV, remember one important area, which I will not give you detail. When such thing is failed, the patient will go for the mechanical ventilation. And if somebody is going to be mechanically ventilated, it will be definitely when you are considering an ARDS, especially when the ARDS is so much severe. Remember, there will be fewer devices about the ventilation and many blink system and many of the curve there. Don't afraid. People are just afraid whenever they go in front of the ventilator. I say there are two devices that usually work on the part of ventilator. One is called the assist mode. Another is called the control mode. Assist mode is nothing. It's just the CPAP and BiPAP. All you have to give it to the machine. This is called the assist mode. And about the control mode, there are pressure control, there are volume control, and there will be pressure control over volume. Now, this all thing will be carried out by machine. So the difference is that in the control mode, everything will be controlled by machine. In the assist mode, most of the thing will be controlled by the people himself or the patient himself, with the two exceptions. One exception is the FiO2, another is the PEEP. Machine will only fix up FiO2 and PEEP. And remember, for any ARDS, the principle is pretty simple. You make a low tidal volume and you make a high PEEP. If you generate more tidal volume, there will be a barotrauma, the lung will be punctured, there will be pneumothorax. And if you get less amount of PEEP, the lung will be collapsed. So this is the principle of the ventilation system. I'm not going to go detail of that one because we have a lot of emergency to tell, right? The second thing about the emergency sepsis and septic shock, I will not give a lot of slides, just one slide. The pathophysiology, I will not say anything, but what I like to say that sepsis has variable grade, extending from mild to severe. But whenever there is a severe infection, severe inflammatory response happen, you all know that many of the cytokine came out through the virus as well as this interface, macrophage, and many of the lymphocytes came up with all their chemistry and the cytokines and the biomarker, leading to the vasoconstriction, effect of the different organ system, including the heart, including the kidney, including the liver, so the multi-organ can be involved. So although whenever sepsis and septic shock terminology came up, we thought that, is it a bacteria? But right now, the terminology has said that it could be a viral sepsis, and COVID-19 is one of them. So what will the principle of management? Very simple. As early as possible, you start a fluid, several liters. Only choose the crystalloid and colloid fluid, not to starch, no high chloride. Antibiotic, within an hour, it should be administered. After these two things, if somebody needs the blood pressure is low, you can give the vasopressor, norepinephrine, epinephrine, vasopressin. Do not use dopamine. Do not use any phenylephrine. Patient is preferably given enteric feeding. Patient will be provided the insulin therapy because many of them will have impaired glycemia. Do not go for deep sedation. And very recently, lung protective ventilation that I am telling you very recently is going to be beneficial. And there is a big question whether the molecular targeted therapy will be beneficial or not. It may sometime, but the principle is that we should not go for any goal-oriented therapy in sepsis. We should not go for an early goal-oriented therapy in patient with sepsis. Now let's come to the cardiovascular emergency that I'm telling you. They said that heart inflammation can be life-threatening, but it can be happen in people who do not have any pre-existing risk factor, so that a COVID-19 infection, a new infection, can involve the heart. That's the simply statement by Peter Levy. Now, why I'm saying this? Because COVID-19 is a multifactorial and multi-system disease. It does not necessarily always mean involving the respiratory system. It can involve the endothelium because there are ACE2 receptor. It can directly involve the myocardium because myocardium has also ACE receptors. And it can involve the GI tract because it also has ACE receptors. But when the viral infection happens to the part of the cardiovascular system, it can cause a serious systemic inflammation. And this serious systemic inflammation in a pre-existing patient can have a serious impact, and even without any previous cardiovascular disease, have direct impact. So you can develop direct infection of the myocardium leading to myocarditis. You can involve the inflammation leading to the myocardium arrhythmia. It can involve the coronary arteries by means of involvement of direct virus leading to inflammation, acute coronary syndrome, and also it can jeopardize the functions of the heart leading to the heart failure, and the stress that can lead to development of the Takotsubo's cardiomyopathy as well. So you can easily see there are a lot of impact on the part of heart by means of COVID-19, either direct or by means of inflammation. And beside this, inflammation can lead to thromboembolic manifestation. As you all know that immunothrombosis is the mechanism of development of coagulopathy that can also impact on the part of cardiovascular system, doing the myocardial infarction or maybe coronary syndrome as well. And beside this, there are drugs which can also have a potentially cardiovascular territory side effect, like the hydroxychloroquine, like the azithromycin, sometimes the remdesivir as well. And also, it is said that if somebody has an underlying comorbidity, there's a chance that 13-fold odds that you can have the serious amount of acute cardiac injury in patient with COVID-19. So what may be the emergency? Acute onset heart failure, arrhythmia, acute cardiac injury including myocardial infarction, type B, and the myocarditis and cardiac arrest. And you can see that a viral infection which can lead to pro-inflammatory state and later on developing a serious amount of metabolic demand in the heart can lead to such amount of emergency. And it has been proven that if we do the troponin I, and if it is more than 28 picogram per ml, there's a 17% chance you can have a cardiac injury. This is just very early study in China, later on proven different countries of the globe, including America as well as Europe. And also, for all comers, there has been found to have 17% of the cardiac injury. Significantly, it has been found more and more in non-survivor patients of the COVID-19. So you can see the emergency that can develop. So cardiac biomarker, is it important? I say yes, it is, because it has been found that the biomarker in the form of proBNP or troponin I, this kind of biomarker, including IL-6 and sometimes the CRP, can have a longitudinal impact if we consider about monitoring it to develop acute cardiac injury and worse prognosis. So what will happen if there is a consideration of acute emergency? If there is acute coronary syndrome, we can again divide it in two parts, STMI as well as non-STMI. If it is a consider of STMI, you all know that there is a STMI network. It means that as quickly as possible, you can take him to a hospital where there's a 24/7 angiography and the angioplasty services there. The choice is primary PCI. Now, for the COVID-19, as because there may be some delay, they said, can we extend it up to 60 minutes? I say yes. You can also allow for extra delay if it is a COVID-19 pandemic. having STMI, go for the primary PCI. But if the levels are actually 24/7 cath lab, but we do not have any such amount of timing in our hand, then you can go for fibrinolysis. But if it can come within 60 minutes or mild delay, go for the primary PCI. But there will be certain country like us, which doesn't have any 24/7 cath lab in every hospital, then we can consider about giving the fibrinolysis. That's the simple principle of STMI. Now for the NSTMI, I would say check the risk, whether it is low risk, intermediate risk, high risk, or very high risk or not. If it is a very high risk, means that patient is hemodynamically unstable, life-threatening arrhythmia may be there, maybe patient have acute heart failure, go for the STMI pathway, and primary PCI is the best one. Otherwise, the non-invasive testing as well as conservative measurement, including the fibrinolysis, will be the choice. Arrhythmia, there has been said that in the ICU setting, 44% patient of this COVID-19 will have a cardiac arrhythmia leading to emergency. And also, these are significantly more common in the critical care rather than non-critical care illness. And telemetry also shows that cardiac biomarker has a direct correlation with the severity of arrhythmia. The commonest arrhythmia has been found to be atrial fibrillation or atrial flutter, but the ventricular tachycardia as well as ventricular fibrillation has also been reported. Now, there are pathway, I'm not going to be detailing anything, but important issue, the anticoagulation will be very much crucial when we are dealing about the atrial fibrillation, atrial flutter, because it is there in the management protocol of the COVID-19, but you augment it when you are considering about atrial arrhythmia. But for the VTA and VF, it will be very difficult. The standard protocol of the BT-VF will be followed, whether it is monomorphic or polymorphic BT-VF. I'm not going to be in detail about that one. Another interesting that COVID-19 has been shown at many Brugada syndrome as well as CPVT. Now for the Brugada, as well as if we say that there is a paroxysmal ventricular tachycardia, I would say that we can start it with a conservative, including the beta blocker and flecainide. But if the patient is hemodynamically not stable, then go for the emergency protocol of cardiac arrest resuscitation protocol, but avoid adrenaline, avoid isoprenoline, avoid dobutamine, and avoid alpha beta blocker. QT prolongation and management is the standard protocol of the cardiologist. I'm not going to say anything about this, but COVID-19 medication at the same time, QT prolongation management through their standard drug will be consideration about this emergency. How about myocarditis? There will be many cases of the fulminant because it has a direct as well as immune-mediated injury. And interestingly, the POC echo actually goes for the LV dilatation, and sometimes the global as well as multisegmental hypercontractility has been shown. Interesting, methylprednisolone and immunoglobulin has been found a wonderful protocol in this case of the myocarditis, and there is a serious amount of recovery. Many of the areas of around the globe actually chooses plasmapheresis as well as cytosol, which is extracorporeal cytokine absorber, to deal for the cytokine storm that is causing myocarditis. About the acute heart failure cardiac shock, very serious condition because they are suddenly considered about the communication with the coronary syndrome, and standard protocol for there is always be there by means of cardiologists. It always need a multi-sectoral involvement of medicine, cardiologists, others for such amount of dealing, because the non-survivor group are 52% versus 21% in this patient having acute heart failure as well as cardiogenic shock of emergency in COVID-19. And the management protocol, I'm not going to give you a lot of things, but guideline-directed medical therapy like the beta blocker or the alpha beta blocker, AC inhibitor, ARV, and even the sacubitril and valsartan, mineralocorticoid receptor, can be continued, especially for the heart failure with COVID-19. Acute pulmonary embolism has been one important serious amount of emergency in the COVID-19, especially in the ICU and sometimes the pre-ICU. Anticoagulation has been provided as a standard protocol in many of the severe and critical illness of the COVID-19. But a monitoring and increasing raise of the D-dimer has been found to be responsible for developing such emergency of pulmonary embolism. I would say that the turnover of this low molecular weight heparin to standard heparin, or sometimes the fibrinolysis, if you consider about the pulmonary embolism developing quickly in the ICU setting, can be life-saving in many other areas. Although Prophylaxis anticoagulant still is a choice, but sometimes you can choose for the fibrinolysis if you can confidently consider about pulmonary embolism. Neurological, there are many acute emergency complications. I will not give you a lot of things, but look at this one. Patient can develop stroke, even on the top of the COVID-19. Patient can develop hypoxic metabolic encephalopathy. Patient can have a Kawasaki-like encephalitis. Patient can have viral encephalitis, can have viral meningitis, can have viral endothelitis. And also in the post-infectious, just within the overlap of the infectious, there will be GBS, acute disseminated encephalomyelitis, and acute necrotizing encephalitis. So can you see how much emergency can somebody develop? There's a one publication done by the Journal of Bangladesh College of Physicians, which shows that hemiplegia was found 56.60% patient having an COVID-19 in our patient. Can you imagine? Acute confusional state, 22% cases. 13% has altered mental status, and seizure also 1.8%. So you can see it's a huge emergency problem of this one. This is a one case which actually shows a young patient having a prolonged COVID in a 43-year-old. Suddenly he actually developed such amount of left-sided hemiparesis and the eye sign. And when the MRI has been done, look at one, total occlusion of the left internal carotid artery. So such amount of large infarction has been observed even without any previous risk factor at all in COVID-19. Intracranial hemorrhage having proven in many areas. This is the one another case to show that a large hematoma with a cerebral edema with a normal loss of the gray as white matter in a patient, especially male, who has a serious amount of GGO in their CT chest of the COVID-19. So you can easily see it's another complication. Although somebody say whether the patient was receiving the anticoagulant or not, but it has been found that even without anticoagulant, there are case report of hemorrhagic stroke. This is a wonderful MRI actually to show the acute necrotizing encephalopathy bilateral distribution. And look at this one. This is not hematoma. This is the actually the demyelination and hemorrhage that can develop. And the encephalitis and encephalopathy, I'm not going to say anything about the pathophysiology, but it can develop an emergency situation because the patient can die pretty quickly. So the meningoencephalitis has also been proven in many other cases. And look is the hyperintensity in the MRI showing the particular territory involvement of the MRI showing in this case of meningoencephalitis. So this emergency transport actually is actually patient presented with a seizure disorder, having a neck stiffness. And when the patient was treated in the line of the COVID-19 serious case, the patient recovered. So this is another area where the metabolic and hypoxic encephalopathy will be invariably seen. And look at this lung here and look at this bilateral involvement in this putapenal area having the metabolic as well as the toxic encephalopathy like. Some may say, is it a methanol poisoning? This can also be a big question, but actually the case was nothing but a COVID-19. This is another MRI actually showing the metabolic. You can see the toxic encephalopathy, the hyperintensity matters. Marked hyperintensity shown in the basal ganglia region. Delirium is another acute emergency has been experienced in the 20 to 30% of the COVID-19 patient, and 60 to 70% actually of them actually need an intensive care service. It can be developed either by means of direct CNS or inflammation. Seizure, many series are there. I'm not going to say detail about anything, but the viral invasion of CNS, hypoxic injury, as well as metabolic and septic encephalopathy, all stimulates the seizure to develop. And there will be some generation of the drug that we need to give broad spectrum antiepileptic in these cases to save the life. CNS manifestation in the form of acute disseminated encephalomyelitis or edema has also been reported 7 days onwards. It's not an emergency. If you can give a high dose of the steroid and methylprednisolone, you can save the life pretty quickly. GBS in the form of acute myopathy has also been immune mediated. Few case report. Right now the case report is increasing and it becomes an acute emergency because it can involve the respiratory system, part of the GBS, and lead to respiratory failure. What about the long COVID? Does it cause an emergency? I say yes, we need to catch the tail pretty quickly as well because it can lead to emergency. One example is that a Dr. UA who came to me as a post-COVID-19 state after 4 months or 3 months, although she has been tiring, extremely tired and fatigue and palpitation, came up newly developed the hypertension, newly developed the GM after COVID, having a fluctuation of the oxygen saturation, and was actually treated in the line of protein fatigue syndrome with sedatives. When I do some respiratory function and cardiac MRI, I found that there are some serious issues, like the edema in the form of the STIR showing the hyperintensity sign and evidence of these gadolinium enhancement territory. And these actually are two criteria of Lake Louise to say a diagnosis of myocarditis. I started methylprednisolone and immunoglobulin, and she is completely cured now. Later on, this kind of 5 patients is actually under my care, and also many of the cardiologists actually dealing this sort of myocarditis and perimyocarditis, and who are actually doing a very problematic in their territory of life. Now, last of all, I will say something about the COVID-19 vaccine-related emergency. Two, one is anaphylaxis or anaphylactic reaction, and second is a vaccine-induced thrombolytic thrombosis or TTS. I'm not going to say detail about the anaphylaxis pathophysiology, but important issue when antigen attack at B cell, we develop IgE antibody. That IgE antibody develop within the mast cell or basophil, then the calcium influx happen, chemical mediator release, it can affect the lung, heart, and skin. That is causing the anaphylaxis. So what happened that an immunological activation or non-immunological activation can lead this anaphylaxis. So what happened is that when we are providing vaccine, either through the non-immunologic activation or by means of immunological activation, can develop anaphylaxis. And remember, the RNA-based vaccine has more prone to develop anaphylaxis rather than non-RNA vaccine. As because there are some component in the RNA that will causes the stimulation of the anaphylaxis. How shall we define? I say, check the skin and respiration. If somebody wants to make a diagnosis of anaphylactic skin, the principle is that you need to always have some skin lesion. So one major dermatological and one major cardiovascular or respiratory criteria is enough to make a diagnosis of the anaphylaxis. So an urticaria associated with the stridor or bronchospasm or low blood pressure is a diagnosis of anaphylaxis. But if we do not follow this skin criteria followed by this one, then there will be diagnostic uncertainty. So any major cardiovascular criteria will not be a diagnosis of anaphylaxis. A single major respiratory criteria will not be an anaphylaxis unless you have the skin. Pfizer-BioNTech published in the JAMA has shown that huge number of cases to have developed some kind of anaphylaxis. Interesting, 3 of them needed ICU care and recover completely. Rest are actually taken in hospital outdoor service, 1 hour, 2 hour treatment and go home. None of them actually have a fatality. Everyone survived after 1 or 2 doses of the adrenaline. So there was no death. It's a fantastic news. Although 19% were hospitalized, few patients needed 2 to 3 doses of adrenaline, and later on they can go home. So in the anaphylaxis on COVID-19, I will say that the most common symptom will be urticaria, angioedema, rash, and also a sense of throat closure. And this vaccine-associated emergency will be identified in many of the non-anaphylactic or non-immunized cases as well. So a watch together about an hour after giving the vaccine is so much important, at least through by a physician watchful observation. How will you manage? I will be saying 3 drugs, adrenaline, and adrenaline should be the choice. And after adrenaline, if you want to give, go for the chlorpheniramine. The third choice will be the IV fluid. The last choice will be the hydrocortisone. So do not provide the hydrocortisone at the very beginning. It will be always adrenaline. I'm not going to go detail about this unless somebody asks a question. The second emergency of the vaccine issue is the VITT. You all know that thrombotic thrombocytopenic syndrome. This is actually acute thrombus or thromboembolism, which can be generated at uncommon location like central venous sinus, in the abdominal territory, a splanchnic vein, and it is associated with a marked thrombocytopenia. The thrombocytopenia will be less than 50,000 following a vaccination, especially when the vaccine is a non-replicating adenovirus vector-based vaccine. So pulmonary embolism, deep vein thrombosis, coronary artery embolism, cerebral artery can also be involved. But remember, these are the common location and has also been reported in some of the vaccination after COVID-19 with the adenovirus vector base, commonly in pregnant lady. Risk and factors are important to know. When somebody is having a prothrombotic state, get hormone therapy, either obese, cancer, immobility, severe anemia, neurosurgical or post-surgical state will be a risk factor if somebody get a vaccine, can develop TTS. And usually this develop within 30 days, but the range is 3 to 30. I'm not going to say a lot of things about the pathophysiology, but remember, clinical feature. Now, after getting a vaccine within 30 days, if somebody came up with you, I have a headache, I have some renewal or abdominal pain, why I'm suddenly develop breathing difficulty, I'm developing chest pain or limb pain, and also there may be some clinical symptom of atypical sign, you have to deal some of the thrombosis, but in the blood test, you're getting thrombocytopenia less than 50,000 is a diagnosis. So these are the lab work that I'm telling you. Remember, D-dimer will be very high in that case. We do not have any facility of anti-P4 antibody, but if you have a platelet count less than 50 and D-dimer more than 4,000 and unusual site of venous or arterial thrombolism within the 3 to 30 days without any risk factor or having a risk factor after getting the adenovirus vaccine, think you are dealing TTS. This is the management. Do not give platelet. Do not give heparin or low molecular heparin. It will detrimental effect on the part of VITT. Always try to give non-heparin based anticoagulant like Agdatroban, Bivarubin, Fondaparinux will be wonderful. Rivarox can also work, as so also Epixaban and Dabigatran. And sometimes the serious case need a consideration of IV immunoglobulin. I'm really sorry I've taken a lot of time, but this emergency will be never ending in the COVID-19. Be careful, be safe, be cautious. Virus is everywhere, and deal the emergency with emergency in COVID-19 the way I think will be a wonderful for everyone. Thank you very much for your patience here.
Thank you so much, sir, for your concise, to the point, excellent, yet very informative presentation. I can see the whole comment section flooded with questions, but we won't be able to answer all of them. We'll select few as the time is short. So, without doing any further delay, I would like to request MS Arefin Patwari sir to start the question answer session. MS Arefin Patwari sir.
Thank you, Professor Mohammad Robed Amin sir, for your excellent delivery here. And hearing from you is always a great opportunity for us. Now we will get into the question answer session, and I'm seeing a lot of questions here before us to be answered. But due to the time constraint, we'll not be able to answer all the questions. Here I have got a question that if we treat a patient with ARDS or septic shock who is in a severe COVID-19 patient getting already the dexamethasone 6 milligram per day, if we need any corticosteroid, whether we will change the dose of corticosteroid due to ARDS, or if we know that treating the bundle sepsis, sometimes we need corticosteroid, or is it use of corticosteroid is a controversy here?
No, thank you very much. I think there's no controversy, Dr. Jewel, about using the steroid. I think there's no problem because we are dealing with the ARDS as well as the septic shock. And septic shock, I told you, there is no contraindication actually to give them. The survival sepsis campaign actually says in the septic shock, you may choose to give the hydrocortisone within the territory of 50 to 100 milligram. But for the ARDS, there have been some separate protocol for COVID-19, which is the dexamethasone. And remember, it is always the corticosteroid effect of dexamethasone, methylprednisolone, or even the hydrocortisone that is going to affect. So there will be no problem if you consider to select a single steroid like dexamethasone in patient with ARDS with septic shock. There will be no problem. But the protocol, of the dexamethasone will be 20 milligram for 5 days, followed by 10 milligram for 5 days.
Okay, thank you. This question was done by Dr. Farhana from Dhaka Medical College. And we have got another question. Uh, uh, it was done by Dr. Jerin from Popular Medical College. Now we are seeing that many patients, after getting the corticosteroid, who are also diabetic also. So after getting corticosteroid, their blood sugar are rising, and if this patient developed hyperglycemic hyperosmolar state, then what will be the treatment protocol in this patient?
Yes, I think this is a very good question. I think the problem is that in a diabetic patient, when somebody is giving the high dose steroid, there's every chance the diabetes will be uncontrolled and can lead to development of complication. My impression is that the first impression you need to go for insulin, because you cannot provide the oral hypoglycemic as in we are providing with injectable form of steroid. So this is the first principle. Second issue, you need to consider to frequently giving the steroid, the insulin in patient who has uncontrolled DM. So sometimes the soluble insulin is given 3 times a day. You can choose to give it 4 times a day. Even you can selectively give in 4-hourly subcutaneous insulin so that the complication will not be there. And if still then somebody gets a development of HHS, there will be protocol for the HHS, which means nothing but to give in fluid properly. And the proper fluid recipient with insulin, with the treatment for ARDS will be, I think, enough for this patient. But remember one important theory about the steroid, there will be always steroid there in the COVID-19 severe critical illness. Do not give steroid for more than 10 days. It is always 7 to 10 days. You always try to give dexamethasone because recovery trial proven every benefit over there, around 44%. Now, what about the other steroid like methylprednisolone and prednisolone, hydrocortisone? The recommendation of WHO says that other steroid will be chosen if the facility does not have available dexamethasone in their hand.
Thank you, sir, for your nice answer. There is another question from Shoei Sorority Medical College. It has been done by Dr. Osman. He wanted to know that multi-system inflammatory syndrome in COVID-19 patient. Is this an emergency?
Yes, it can be emergency. Remember, I show you the sepsis and septic shock. Remember, when somebody has a sepsis, there will be many stages. The stages actually extended from the mild to severe. So whenever you are considered about multi-system involvement, then it will be always an emergency because you are dealing some of the organ like heart, lungs, kidney, and liver. So that's the reason why you can say that any organ failure need an ICU care will be an emergency, and it has been defined in the critical case definition.
Okay, thank you, sir. I think actually he wanted to know the multi-inflammatory syndrome in children, possibly that is mimic of Kawasaki disease.
Yes,
I think.
Yes, thank you, Joel. I can get right now. Multi-inflammatory system disease in children has been also one important emergency. Why? Because in Europe and America, it has been found around 96% of the patient was dealt in the ICU care. Okay. The important issue is that if some of the children actually develop a rash, having a palpitation or cardiac sign, and a GI sign, if this sort of sign develop simultaneously in a COVID-19, you are dealing MISC. The standard Kawasaki disease will have 3 organ involvement, but it will not be simultaneous, but a consecutive. It will take days to develop another system. So that's the reason why, because simultaneous involvement, it becomes an emergency.
Thank you, sir. Today we are lucky because we have got our 2 panel of experts here, Professor Major General Azizul Islam sir and Professor Hafiz Sarder sir with us. Sir, would you please add something? Already the questions answered here. If you are interested, you can add anything.
I think Hafiz sir need to unmute.
Hafiz sir, please unmute yourself. Am I audible to Hafiz sir or Professor Azizul Islam sir?
Actually, yes, I can hear you. You are
Yes,
quite
sir.
audible to me. I
Yes, sir.
think we during our panelist opinion, we will give our opinion.
Okay, thank you, sir. So now we are again getting into our question answer session, and we have many questions here. Possibly due to time constraint, will not be possible to answer every question. So we'll try as much as possible. Dr. Pulak from Borishal Medical College Hospital, he actually wanted to know, is there any gastrointestinal, renal or ocular emergency in COVID-19?
That's a good question. I will say that yes, I told you about the hypercoagulable state. Now, this coagulable state can develop the thromboembolism even in the GI system. Sometimes it could develop the acute intestinal ischemia. That could lead to emergency, which I did not detail about that one. About the eye, there has been finding of the conjunctivitis and also the irritation of the eye. But the acute emergency of the eye or like a blindness or other thing has not been reported. But the acute retinal thrombosis after getting a vaccine and a few cases of the hypercoagulable state was there, so that could lead to an emergency eye care. And last of all, another system that you are saying, Dr. Joel, eye, intestine, and renal. You see, the renal is they say that acute kidney injury is more common in patients with a serious to critical COVID illness. But luckily, if the standard protocol is maintained, the recovery from this acute kidney insult is good. But if a patient has already been a previous CKD patient and newly developed AKI on a critical illness patient with COVID-19, then it can become a very serious emergency and can need an urgent dialysis as well.
Thank you, sir, for your wonderful answer. Dr. Reddy from Dhaka Medical College Hospital, she wanted to know that is there any standard protocol to use the thromboprophylaxis in severe COVID-19 patient who is also suffering from severe dengue?
So a patient having a severe COVID with severe dengue will be unlikely because it has been found that when the two viruses is there, one virus is actually become more predominant one rather than non-one. So you can get a mild dengue with severe COVID, or you can get a mild COVID with severe dengue, no problem. But both of them severe will be unlikely. Still then, the recommendation will be very simple. For anticoagulation, there will be relative contraindication if the platelet count is less than 1 lakh. If the platelet count is less than 50,000, you cannot provide anyone having anticoagulant in the form of heparin and other things. So you can easily judge that because one state is hypercoagulable, another is the bleeding DIC, it will be managing each other. So you do not need any drug.
Okay, thank you, sir. Professor Sabrina Yasmin from Bardem Hospital, we give thanks to you for joining with us. She has presented a case scenario here, a 22 weeks pregnant lady who is suffering from COVID-19. She is severely anemic. Her hemoglobin level is 6.1 gram per DL and platelet count is 110,000 and SpO2 is 96%. What will be the treatment protocol for this patient?
Well, the good news is that her SpO2 is 96%, so I will not say the patient is hypoxic. I say that her hemoglobin is 6.1. If it is a pregnancy induced, or she may also have underneath the cause of the anemia, this must be sought out and it should be corrected pretty quickly because the pregnancy state with the hemoglobin 6.1 can easily go for the anemic heart failure at any time. I will say that please make concentration on the part of our hemoglobin. Don't worry about the platelet count, it still remains 110,000, and the platelet count usually does not coincident with any kind of bleeding manifestation in patients with COVID-19. There has not been such amount studies. The standard COVID-19 treatment will be followed here as because she is not hypoxic. So I will say that a watchful observation and consideration about the treatment protocol of the mild to moderate COVID will be there. Thank you.
Thank you.
And thank you,
sir.
Dr. Sabrina, for listening.
Dr. Palash Poddar, he wanted to know in word, how is it possible to classify mild, moderate, and severe ARDS?
Well, it's very difficult because if you follow the Berlin criteria, I will say that you will not able to do that. But my impression is that when actually ARDS happen, the first week is a viremia, it will causes viral pneumonia. So if any patient came up with you on the verge of the week, I mean day 7, day 8, and day 9, and you are getting hypoxia progressively increases, and you get gut findings in the lung in the form of crackles, bilateral distribution, and if you have an X-ray with your hand, I would not say any CT scan, just an X-ray showing a ground glass or bilateral shadowing, which extends to the part all the periphery and also both sided lung, you are dealing some phases of the ARDS. So this will be a very important finding. And if he is hypoxic, I will say that treat him in the line of the ARDS.
Okay, thank you, sir. Besides the emergency in COVID-19, there are some questions regarding the post-COVID, and so there is a question that if a patient developed dementia after suffering from COVID, that is the post-COVID dementia, how should this patient be treated?
That's another question. I would say that dementia will not be an acute emergency, but important to consider, as because I would say it's a transient period of dementia has been noted in many of the case reports as well as case series in patient with the COVID-19. Now, there has been many MRI finding which has been correlated why the patient has developed the transient dementia, but they need to be closely followed up for a period before making a diagnosis criteria of the dementia to be put up in this patient. There's a long COVID. The long COVID is still evolving, and we have just about a 1 year and a half year data, but this patient need to be followed up extensively. About the drugs, I would say that there are drugs which is used for the non-ischemic dementia that can be chosen here. Sometimes if patient has a progressive loss of the memory within the short period of time. These are all will be conservative, actually.
Okay, thank you, sir. And we will not take any other question but one, and it is the last question. So we are sorry for our time constraint, because it is not possible to take every questions to be answered here. Our last question about the what is the chance of prophylaxis after the second dose of vaccination?
Prophylaxis or anaphylaxis?
Sorry, anaphylaxis.
Right.
Yes,
Okay.
Anaphylaxis after the second dose of vaccination. Who has
Yes,
not developed anaphylaxis after first dose?
Okay. I mean, if somebody doesn't have any anaphylaxis after the first dose, the second dose will have a less chance of developing anaphylaxis. And remember, the anaphylaxis or anaphylactic reaction is more commoner in the mRNA vaccine rather than the non-mRNA vaccine. If somebody has an allergy to an agent, which is one of the component of the vaccine, will be a contraindication to get the vaccine. But if somebody has an allergy or anaphylaxis to other agent, will not be a contraindication to receive the vaccine. Okay, somebody can have an allergy or anaphylaxis to the, I will say that nut, to say some of the food items, some of the specific drug will not be a contraindication to receive the vaccine. But if somebody getting the first vaccine and get an anaphylaxis, will not get the vaccine in the second dose for sure.
Thank you, sir. Thank you, sir, for your wonderful presentation and answers. And now we would like to hear some your feelings after giving your speech here, the SAP Bangladesh chapter, sir.
Dr. Arefin, thank you very much. I get relief at least. You are not going to be asked me any question. This is one. But first of all, I would say that a wonderful actually health talk has been there by our Honorable Governor, SCP chapter, Professor H.M. Nazmul has started. And I would say that it is not started right now. It has been there for months. I would say this is a wonderful academia that he has been created. This is very important because you can see the problem with our medical students, undergraduate as well as postgraduate, is a tremendously upsetting. It is creating serious amount of depression and mental problem. As because they are not seeing their teachers in front, and they cannot go to the patient in front to show the practicality. So at least their academic environment need to be generated and make a continuation in such a way that they can benefit it. And so also us. I mean, it's a learning between the two areas. It's not just a one-way shadow, although I'm telling a lot of things here. But remember, I will be very much careful listening to our very honorable panelists as well as chairperson. That's because it's a learning for me as well. So although I'm giving a talk, and in giving a talk for the Nazmul Ahasan and SCP chapter is a big, I would say the pleasure for me. Whenever I talk, it feels a deep pleasure. I really feel good. And if it gives a small amount of information, if some of our listeners get at least 10 to 15% what I tell today about the emergency, I think my lecture will be a successful one. Thank you.
Thank you, sir. And we are very much grateful to you for managing your busy time for SAP Bangladesh chapter. And we have our two renowned professors of medicine here as our panel of experts. Now we'll hear from Professor Mohammad Hafiz Sarder, sir, Head Department of Medicine, Dhaka Medical College. Sir, please unmute yourself, sir.
Thank you very much, Arefin.
Yes, sir.
And I like to thank first the ACB chapter Bangladesh for arranging so important academic session here. And I am delighted to see our teachers, and especially Nazmul sir and other teachers, and Rubed Amin is a special, always talk very fantastically, and he stresses in some area of his presentation so we can learn more from his lecture. And I am very much delighted to have been a panelist in this session, especially as a learner. I learned many things from this lecture as a learner. I always think as a student, always I am the student of my teacher and will be a student up to my death. So I learned this lecture very much from this lecture. Actually, COVID is a systemic disease. It has so many complications. It is not possible to describe all the complications with this few times. But I must thank Professor Rubed Amin. He concisely described all the complications which we encountered in our day-to-day practice. A few days ago, I have a patient in my chamber who has a mild COVID, 32 years old, has a fever, headache, and his oxygen, his saturation is normal, and he has no other risk factor. He was in the home, and he's getting cured day by day. But on the after 5 to 7 days from my chamber, he called me. He had a severe chest pain, central chest pain, and is sweating. So I am very much worried about this young man, and I suggest this patient to come to emergency in a cardiovascular CCU. So this patient ultimately diagnosed as a non-ST elevation MI and treated properly and survived. So this young patient, we have no other comorbidities, but this is a severe chest pain suddenly, but it's improving his COVID syndrome. So there is so many unusual presentation in COVID emergency. So we should be careful about the patient complaint, patient monitoring system for the COVID. Though they are mild or moderate COVID, though they have no predisposing factor. So the COVID is, so I say the COVID is systemic disease. It is the vasculitis in all the vessels of the our system, brain, eye, heart, kidney, liver, any system can be involved. So a COVID emergency must be account in every a severe symptom which may lead to the death to the patient. So we must be careful about their symptom. From this lecture, our student must be benefited because of in near future their exam, FCBS exam, MD exam, and the MBBS exam nearby. So our student and including me are very much opportunistic to have a learn from this lecture from Rubed Amin. I must thanks Professor Nazmul Ahasan sir for give me opportunity to present in this seminar. Thank you very much. Thank you Patwari for his nice moderation. Thank you very much.
Thank you, sir. And we are very much grateful to you for managing your busy schedule here in for SCP Bangladesh chapter. Now we will go to our honorable panel of experts, Professor Major General Azizul Islam, sir. May I request, sir, you to express your feelings here?
Thank you very much, moderator, for giving me the floor to speak something this occasion. Respected Governor, ACP Bangladesh chapter, and today's chairperson, Professor Nazmul Ahasan, Professor Hafiz Sarder, Professor Amin, Dr. Arefin Patwari, Dr. Prince, and the audiences from home and abroad. Assalamu alaikum and very good evening. Actually, first of all, I express my heartfelt thanks and gratitude for inviting me to join this program as a panelist. And I must appreciate Professor Amin for his excellent and brilliant presentation. I thought that we will be telling some complications regarding the COVID and we'll try to highlight the management. But Professor Amin left nothing for the panelists which to be discussed further. However, as we have we are facing and treating COVID patients for about last 1.5 years, almost all the complications and their managements discussed by Professor Amin. I like to share my one or two experience, one or two patients' experience with you. We have got some patients. Few patients presented virtually with the pancreatitis and the severe diarrhea with the casualty. So we have lost one or few patients due to this severe pancreatitis and the gastrointestinal symptoms, and which we used to call, though these are not the exact nomenclature, presented with the gastro-COVID-like symptoms. Again, we do not know actually still what is the fact. We lost few cases with severe pancytopenia. The patient presented with the fever, cough, and severe pancytopenia. Though we gave the nomenclature might be hematocovid, but still we do not know what was the fact. So we lost few cases due to the pancreatitis and due to the complications of the severe pancytopenia. And rest of the all the complications are discussed by our very learned speaker. Particularly, we have also got some children of multi-system inflammatory syndrome. We have lost one cases, but it was initially during the early time, it was not diagnosed properly by the doctor physicians, and finally, some patients were diagnosed and they were treated with the good outcome. And finally, I like to thank today's chairperson for inviting me to this very important and this highly rich and this valuable program, particularly the complications of COVID, where there is no end of the complications, and most of the complications have been discussed by this very learned speaker, and he has also answered all the questions. So all we have learned, we have benefited from his today's speech. Thank you very much.
Thank you, sir, for your speech and for giving your valuable time here. And we are at the end of our session, and now we will hear from our today's chairperson, Professor H.M. Nazmul Ahasan, who is currently working as the Governor SCP Bangladesh chapter, and he is the former President, Bangladesh Society of Medicine. May I request Professor H.M. Nazmul Ahasan to give your concluding speech and also conclude the session. Thank you, sir.
Thank you, Dr. Arefin Patwari. Assalamu alaikum. At first, I want to express thanks to Professor Amin for his excellent presentation. Professor Amin has proved himself as an indispensable clinician, physician in this country. Dr. Patwari, he has mentioned rightly that I have retired from two innings. First innings from government service, second innings from private innings. There is no third innings yet in ICC test match. I am looking for a third innings. This is my third innings. I am involving all the good physicians in different academic platforms. This is one my job in my third innings. And Professor Amin, during my first innings, I had an opportunity to work with many brilliant clinicians at Dhaka Medical College. Like one of them is Professor Amin, also Dr. Professor Hafiz, Sarder, and Dr. Arefin Patri, and many others at that time was in Dhaka Medical College. Professor Amin, he is a very good clinician. He is very, I think he is very clever enough. He is very energetic, and he has good soft corner for research work and also medical writing. In many national guidelines, his role is he's playing a very pivotal role. Still, all of us, we remember before emergence of COVID in Bangladesh, a couple of months earlier that there was a seminar at Dhaka Medical College at Milan Hall. At that time, there was a presentation on COVID, and Professor Amin and Professor Qazi Tariqul Islam, former governor, they gave a talk on this disease. And still we remember that brilliant presentation. Since then, he is also playing a very important role in management of COVID in our country and prevention. Still now here, but government has rightly picked him from medical college to national level. He is also playing a very good role here. There. Thank you very much, Professor Amin, for your contribution in medical science, in particularly not only Bangladesh. Your contribution, we are proud of you. This COVID, undoubtedly, this is a very notorious disease. Daily, we are getting a lot of informations regarding its management, its mutation, regarding its vaccines. Some are very much disheartening. Today, we got that some possibly vaccine is not going to play any role in future. So sometimes we know in case of influenza virus, it is H1N1. In future, there may be Alpha 1, Delta 1, Alpha 1, Delta 2. So there may be a lot of mutations in future, and what we will encounter in future, we do not know exactly. Till now, we can divide the disease in acute phase during the first month, subacute phase in some literature as first month to 3 months, and after 3 months to 6 months as a chronic COVID. We are losing hundreds, not only hundreds, thousands of people. What is the cause of death? It may be respiratory failure, it may be thromboembolism, it will depend multi-organ failure. Professor Amin has elaborately, nicely, he has mentioned many, but still many yet to know, yet we are to know daily. So this information definitely, I have learned a lot. Definitely all audience, all listeners, they have also learned a lot. I am thankful to Professor, Major General Professor Muhammad Azizul Islam, Consultant Physician General DGMS. We know a lot of patients are being treated in CMH. He is leader there. He has experience. He has earned a lot of experiences there. Thank you very much for giving your time. Another hub is Dhaka Medical College, our premier institution, premier hospital. Professor Hafiz, he is working there. So he has a lot of experience also on COVID. And thank you, Dr. Patwari, for your and Dr. Uh, Prince for your good moderation and anchoring. From ACP chapter Bangladesh and supported by Bangladesh, our prime organization, Bangladesh Society of Medicine. This time we have planned to organize at least 20 to 25 presentations on acute emergencies, acute medicine or emergency medicine, because we know this is very important. Last week we had a very good presentation on acute emergencies in dengue. Today we had a presentation on acute emergencies in COVID, and next week we will have a presentation on emergencies, particularly on sepsis. So this emergency management is very important for every physician, starting from clinical student up to consultant. We are learning I personally, I have learned a lot from today's presentation. Professor, this time I have given this responsibility to Professor Rubina Yasmin. He is behind the screen. She is organizing everything. I must be thankful to Professor Rubina Yasmin, who is Professor and Head of the Department of Medicine, Mugda Medical College. I always get help from past Governor Professor Islam and also Governor-elect Professor Khan Abul Kalam Azad, all members of Society of Medicine and also Advisory Council of ACP. Finally, I am thankful to all listeners and audience for your presence. Your presence always encourages us to do this. I am finally, again, I am thankful to Professor Rubit Amin for your excellent presentation. Thank you very much. I conclude here. Thank you very much.
Thank you, sir.
Sadly,
Salaam.
we have come to the end of
Thank you,
today's
sir.
program. We have learned so many essential things about the management of COVID 19 from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator, sir, for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very important questions. If you joined late or couldn't see the program, there is no need to be worried. The whole session will be present on our YouTube channel. Our next health talk on acute medicine will be held on 12th of August, where Professor Titu Miyasar will discuss on the topic diagnosis and management of sepsis. So, see you all in the next episode. Until then, take care and good night.